Thank you very much, John, to my distinguished panellists and everybody here. I wish to start by acknowledging the traditional custodians of the land upon which we meet and pay my respect to elders past and present. Look, I think this conference has highlighted the latest advances in HIV treatment, testing and prevention. It's obviously work that is transforming healthcare in many countries with outstanding results for those fortunate enough to have access to them. Scientific advances have changed the landscape of HIV and AIDS over the last 3 decades, particularly the benefits of modern antiretroviral drugs, not just for those living with AIDS, with HIV, but also for the community, because this treatment dramatically reduces the risk of onward infection. Today, the life expectancy for most people with HIV in Australia on this treatment is predicted to approach that of the general population. The New South Wales HIV strategy, which I launched on World AIDS Day in 2012, and the 7th National HIV strategy launched 2 weeks ago, call on us to drive down new HIV infections and to use antiretroviral therapy for maximum effect. In these strategies, we've committed to increasing the number of people with HIV on treatment to 90%. Nationally, Australia has around 60% of all people living with HIV on treatment. However, in New South Wales, we are close to 90%. This means it absolutely can be done. But to achieve this nationally and globally, we must drive up testing, treat early, and provide treatment options that are easy to take and have fewer side effects. And of course, in many countries, as we've heard, it's about giving access through education, removing some of the barriers that allow people to be involved in testing in the first place. In Australia, our approach is about consistency of treatment, about continuing education, about accreditation of antiretroviral prescribers, and delivering support in the community. But our focus now is also to integrate HIV into existing programs and services. We do this wherever feasible rather than establishing specialist services, which are often costly and arguably less efficient. Our HIV model of care is based on a mix of specialist and generalist care in hospitals and in the community that has worked well across a number of other chronic illnesses, including diabetes and cardiovascular disease. And we also have to continue to be ready to evaluate and to adapt new ways of delivering care. The new paradigm of HIV as a chronic, manageable illness and the evidence for the health benefits of treatment in preventing onward transmission means that we are learning to be more responsive and adaptive with our clinical service models. Successful and lifelong treatment requires a system that removes barriers. For example, in Australia, we have recently removed the CD4 count restrictions that were previously required to prescribe HIV treatment. So no one now has to delay treatment which impacts on onward infection. We've also reduced the financial strain of treatment by doubling the amount of medication that can be purchased at any one time. This has effectively halved the co-payment required under our health system. Another very recent reform from my colleague, the Federal Health Minister, is that HIV medications can now be dispensed at community pharmacies rather than only through hospital pharmacies. Since becoming Health Minister in New South Wales just over 3 years ago, after 16 years in opposition following being the health spokesman, I have driven major reforms to our health system generally, with health promotion and prevention focused on keeping people healthy and out of hospital. There is clear evidence that investment in prevention and providing care in the community results in better patient experience and reduced hospital and healthcare costs. In New South Wales, our reforms include a devolved governance structure where decisions are made as close to the patient as possible, which of course is very important in the context of HIV/AIDS. We have developed new purchasing and performance frameworks, service agreements and surveillance systems so that we can monitor patient activity. We now have access to more data than we've ever had before. This increases our accountability and performance and helps show us where we should invest. You're talking about domestic investment. In my opinion, demonstrating the value of what we're doing is a way of encouraging governments to see the financial sense of domestic investment. We are working directly with our service providers, which in New South Wales include local health districts, sexual health clinics, our AIDS Council, ACON, to embed HIV testing and treatment into existing work and purchasing frameworks. We've also changed how we deliver services, and this is helping free up further capacity rather than having to invest in additional services. Not only does treatment allow people to live full and productive lives, it also has an important public health benefit by preventing the transmission of HIV to others. So modern HIV treatments are cost effective. Economic modelling predicts that the treatment as prevention approach is also cost efficient, and as infection rates decline, it is likely that the cost associated with HIV treatment and care will also. I am confident that we can deliver lifelong ART not only in Australia but globally. I see such fierce determination in our effective communities, our leaders, our scientists and health professionals to end the epidemic. Political leadership is, of course, very important, and I know I speak for all the Australian health ministers in pledging our commitment to providing lifelong care for people with HIV. And I make that commitment as a chair of the Australian Health Ministers Council, where all of us have signed up to a strategy that makes that commitment. I thank all of you for your attendance here today.